Hey, good morning, everyone. It's Wednesday, October 19th. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. It's been 2 months since we've had a status report on COVID in the metro and the region. Today, we bring you another news and community conference with 13 chief medical officers and infectious disease specialists, including myself, from the metro and across Kansas. Last August, the University of Kansas Health System had 34 COVID patients. Since then, the count for many of us has gone up. Transfers were tight, staffing low, supply chain challenging. We'll look at where we've been, where we are today, and where we think we are headed this winter. As some people say, a viral swarm, especially with flu cases expected to be high. Over the next 45 minutes, we will hear if there's been any improvement in the healthcare system around the state. For a long time, it's been under great stress from the sustained period of high transmission and workforce depletion. After we hear from our physicians, we'll open up this report or this session to reporters and to questions from the community. Members of the community should put their questions into the chat feeds in Facebook, YouTube, Twitter, or email us at the Medical News Network at kmc.edu. Jessica Lovell will monitor those feeds for questions. Let's begin. All right, here's where we are this morning in the Kansas City region, according to data from the Mid-America Regional Council, also known as MARC. These are numbers from the last 2 months since we had our last Chief Medical Officer report. The daily average for new cases, 143. The average daily new hospitalizations, 62. The average daily new deaths is at 1. Now here's a look at the national picture in this current heat map from the New York Times. You know, this map is just a lot paler than it was before. Remember, even a few weeks ago, we saw some really darker dots kind of in the mid-Atlantic, northeast seaboard, and also somewhat out in the west. But really, the map's just gotten quieter right now, which we like a lot. And yet, there's still a lot of stress in the healthcare system. Let's talk about why. Let's go to bring in Dr. Richard Watson, the co-founder of Motient. We've had Dr. Watson on the program before. Dr. Motient, thank you for coming back. Your company helped create Mission Control. It's the app that the Kansas Department of Health and Environment uses to connect rural hospitals and trying to transfer patients. It allows us to monitor how long and for what reasons people are not getting transferred back to the out of a rural hospital into a hospital with a higher level of care, especially when they're sick and they need that help. So, Dr. Watson, you've been keeping track of bed capacity during the pandemic. How are things now compared to 2 months when we last spoke?
Well, thanks again for having me on this morning. It's really a little depressing to think that we are where we were 2 months ago. Without a doubt, the dynamics that are in play now are going to be with us for a while. And even as we see COVID on a downward trend, we realize that we essentially burnt the house down through the last 2 years of pandemic, and we went through workforce. We went through a lot of processes, we went through dollars, and now we're trying to figure out how we build it back and what that time frame looks like. So if we can go to the graph, I'll show you where we've been a little bit and where we're headed. So this is tracking a year long. It's a graph that's familiar if you've been on these calls before. The big peak in the middle is obviously that curve that took us through 2021. To the left of the curve is a capacity we had prior to that. And you can see it's relatively good. Low means good here. On the right side of that curve, we never dropped down to baseline coming off of that peak. In fact, if you look at numbers and times and everything about moving patients in the state, we see that we're at a level that we haven't seen for this long a period of time ever. And the story here is that there's a significant number of EMS workers on the sideline. We're probably down 15 to 20% in the nursing workforce. We're seeing pretty much standard rates of disease in many areas, but we're seeing protracted waiting times because of these issues related to not only nursing workforce, but EMS resource. And we're finding that certain segments of the healthcare are really backed up, mental health, behavioral health being some of the worst, but also then even some of the time critical diagnosis, depending on time of day and day of week and how stressed the system is. Local EMS that becomes one in, one out, and is unable to move people between facilities and has to stay in the county They don't allow the system to work like it needs to work when we need to move patients in the state.
Wow, that is a scary thought, because we're just headed into the winter where traditionally things are more logjam. Predictions about a tough year for influenza. We saw that in the southern hemisphere this year, and now kind of already trending up in influenza in multiple states in the United States. But also this prediction about different variants of COVID perhaps being more resistant to therapy. That concerns me, and low staffing levels. I'm worried. How about you?
Well, I mean, I think shame on us if we don't do everything we can to be prepared right now for what potentially could be. We have to be able to put stopgaps in place to mitigate to the best of our ability. Rural hospitals need to be looking at how we can keep more low acuity patients. We need to focus on how we move patients back down the chain once they're at the higher level of care. Can we repatriate people back to their home base more quickly? And let's open up as many of these resources as we can. We can't make new nurses overnight. We can't find new EMS workers overnight, but we've got to be more creative with our resources.
I think that's right, and you're darn right about we were trying to find more workers. I think you'll probably hear that from all of our CMOs today, that we're all struggling to get more folks in, and it's also a challenge when you think about it in an ECMS standpoint. Or an EMS standpoint. Here's a question for you. Do you see a higher mortality rate in emergency rooms right now in patients who are waiting to be transferred than you did before?
You know, right now, when we measure the capacity index on a 1 to 3 scale, 3 meaning absolutely no capacity, 1 meaning normal capacity, we know that as we crest that 2.5 number, that it begins to change the waiting times very significantly. It's a logarithmic curve. And as we get close to 2.7, that's the area where the system starts to fall apart. Right now, mortality rates are at a normal level. But again, we're precariously close to that 2.5 level. And we know once we get to the 2.7, 2.8, that we begin to see things that indicate the system wants to collapse. And I think that's the part where we need to make sure, okay, our mitigation's in place to be able to look at how we would solve for those issues when they come.
Wow. So, Dr. Motient, are you tracking the flu in the region? And if so, how are we doing?
You know, we do from a periphery, and we have conversations around the nation with different health systems and different state governments, and we hear where people are at this time, and very similar across the U.S. About where the flu story is right now, that the number of cases looks to be higher than it has been before, that immunity levels are lower than they have before. The question is, you know, what will be the real story, and how will COVID into that mix change the actual dynamics of what we would normally think of as a flu season?
Yeah, I think that's right. With a very low uptake of booster shots across the country, I think we may be more vulnerable than we know, both to influenza and COVID this winter, which could, you know, you're not trying to be an alarmist, but it is concerning, especially when you look at that baseline for rural hospitals and the inability to transfer and not having enough EMS workers. And if they get sick during a pandemic, or if we have a worsening of COVID and influenza, then wow, then we are going to be strapped, and that's a concern.
It does not take a lot of abnormal to make what we're going through now very terrible. I mean, I just don't think there's a way to look at it. It just takes a little bit of push, and we're right back into the mix. So. Yeah.
Geez. Okay. Well, thank you very much for joining us. Hang on there. I'm going to turn now to our CMOs and kind of go through our inpatient numbers across the region. And I'm going to start with Dr. Lisa Hays, who's the CMO for Advent Shawnee Mission.
Morning, Dr. Stites.
Hey, good morning, Lisa. How are you?
I'm fabulous. I'm happy to report that we currently only have 5 active inpatient COVIDs at Shawnee Mission and 0 at South Overland Park Hospital. We have none in the intensive care unit and none on a ventilator, which is excellent, and currently have 5 employees out with COVID, all of those being clinical. Our main issue continues to be staffing, trying to make sure that we can take patients that are being admitted from the ED up to the floors, and making sure that we have safe staffing ratios, for all of our patients on the inpatient floors as we're trying to pull those patients up from the ED. Our main focus here has been on vaccinating our employees. We have our flu vaccine clinics going on currently, and also concurrently the new bivalent COVID vaccine as well.
Thank you, Lisa. I love those zeros in the ICU and the zeros on ventilators. That is great. We've seen a few folks hit that. Dr. Heather Harris joins us from HaysMed. Heather, how are things out west?
Good morning. Yeah, we continue to have 1 to 2 inpatients of COVID daily. No ICU, no ventilators as well. So we're pleased to have that. We continue to be at times certain units at capacity. So obviously, as we begin to enter, the more sicker season of flu and I'm sure increased COVID hospitalizations, that will continue to strain the system. Again, same things everyone else is seeing, nursing shortage, and then trying to care for all the folks out here in Western Kansas. So it will be a challenging season over the next few months. It seems like this spike always seems to happen after Halloween as we continue to go through the fall and the winter.
All right. Well, I'm going to hope that Halloween and all those things are good news out west and we keep it calm. Let's try. All right. Let's turn to Dr. James Stewart. Dr. Stewart is the CMO at North Kansas City Hospital.
Yes, thanks, Dr. Stites. We have currently 16 active infections in the hospital. We have one of those in the ICU and none are on ventilators. In terms of employees out, we have 8 out currently, and for the month of October, so far, we've had a total of 29. And I think census is a problem. If you look at our census today, it's 88% of physical beds, but if you look at the census in terms of staff beds, we run closer to 100% nearly every day.
So we call that pretty busy then.
Yeah.
All right. Thank you, Jim. Now I'm going to turn to Dr. Elizabeth Long, CMO at Olathe Health. Dr. Long, how are things out south there?
Good morning. So we have basically single-digit COVID numbers, and we've been enjoying that for the last couple of months. We have nobody in the ICU. We have currently 4 inpatients, all on either room air or like 2 liters. So we are doing well regarding the COVID situation. However, just as everybody else is letting us know today, there really isn't much cushion. And so what we are seeing is that our case mix index continues to be high, which means that the acuity of our patients are higher and taking more of our resources. So each patient seems to take more resources. And so there is obviously strategies in place to try to mitigate that through the upcoming seasons. And we are as well doing we call it FluVid, the flu and COVID together, trying to, did you like that?
I like that, yeah.
Doing clinics as far as trying to get the bivalent COVID vaccine into everyone that we possibly can, as well as the flu shot as well.
All right. Well, thank you. We'll keep track of that FluVid too. I like that. Dr. Kevin Dishman is the CMO at Stormont Vale. How are things in Topeka, Kevin? Oh, hey, Kevin, I think you're muted. Don't worry, it's only been 3 years. Don't feel bad about it.
How about that, Steve?
I do that all the time. Yeah, don't feel bad.
I tell you what, you'd think I'd learn. We're experiencing the same things that you've heard from the other CMOs on the call. Concur with Dr. Long. We're at capacity most all the time. We have 7 inpatients, one of those in the ICU. One of our big concern is certainly winter is coming, and we're starting to see most of our hospitalized COVID-19 patients are the immune evading Omicron spinoffs, and emphasizing the importance of getting the new bivalent vaccine. But we're also seeing a surge in RSV, enterovirus, rhinovirus, and particularly, of course, in our pediatric population. And we're seeing our pediatric intensive care unit start to see those RSV cases too. So This year, while we, I think, escaped during the COVID-19 pandemic, some of the flu and viruses because of the mitigation things that we were doing, I think this year we may see a resurgence, and that's a big concern for us.
Yeah, not a welcome resurgence in this case. Sometimes you welcome the resurgence. This is not the welcome one, is it?
No, it's not.
Dr. Jackie Hyland is CMO at the University of Kansas Health System on our St. Francis campus in Topeka. Jackie, how are things for y'all?
Things are going well. Good morning, everybody. We have been kind of in the single digits as well. So today we just have one COVID positive patient, medical status. We've seen a few that have been in the ICU requiring vapotherm. We haven't had anybody ventilated for quite a while. We have seen the flu vid that Dr. Long mentioned. We had someone in the hospital over the last week or so that had tested both for influenza A and COVID. So we continue to make sure that patients who are inpatients are vaccinated for both flu and COVID when we can provide that for them, also providing that for our staff. And we are seeing about 5 to 8 associates isolating over the last month or so. And staffing is a huge issue in nursing, I think in a lot of different areas. So, really worried about that. Lots of gratitude to those on the front line who are caring for all of our patients. So, and then supply issues, particularly with local anesthetics, that's been a big one. As an anesthesiologist, it's interesting how, one shortage in an area will affect other areas like our different spinal trays or epidural trays, and we have to get creative there. But luckily, we have practiced a lot about our ability to switch really quickly. And so I think there's been a lot of new skills that have been developed over the pandemic, a lot of new relationships, but continue to make sure that we're preparing for the winter. As Dr. Dishman said, winter is coming.
Winter is coming, isn't it? And you felt it this morning, that's for sure. All right, Dr. Mark Steele, thank you, Jackie. Dr. Mark Steele is the Executive Chief Clinical Officer at the University of Health Truman Medical Center. Dr. Steele, how are you, sir?
Doing well, Steve, and good morning, everyone. Pretty much a similar story here at University Health. I'm pleased to report that we have our lowest number of cases of COVID since the pandemic began. We have a total of 4, and only 2 of those are active, none in the ICU and none on ventilators. Like the others, we have sort of single digits numbers of workforce members are out related to COVID. Our test positivity rates have gradually dropped down and currently are running about 3%. So that's a lot better than what it used to be. Like the others, staffing is a big challenge for us. We fortunately, at least as things sit currently, we're able to manage the volumes that we have. As was mentioned, our occupancy rates for our staff beds run very high. And fortunately, we're not having any equipment or therapy challenges. And like the others, we're certainly busy giving the bivalent COVID vaccines and also the flu vaccines.
Thank you, sir. Dr. Edward Kemmerer, and hopefully I said that right, is the Chief Quality Officer and incoming Chief Medical Officer for Mosaic. How close was I there, Dr. Edward Kemmerer? Is that pretty close on your name?
That's pretty good.
Oh,
Kemmerer.
Excellent. Excellent. Thank you.
Mosaic represents kind of Northwest Missouri. We have 3 hospitals up here. And so the story is identical. We have 10 people in the hospital. We have nobody on a ventilator, nobody in the ICU. Positivity rates are low. We're running about, we're single digits with regards to our staff that are out as well. So those are all, virtually an identical scenario. This is really about workforce, right? That's the issue. This is not a therapeutic issue. This is a workforce. This is going to be a workforce problem for us, and we're on the exact same boat everybody else is. So we look at this as a workforce problem moving forward. And that's really kind of the state of the union for us. We've had 5 positive flu cases each of the last 2 weeks. That's system-wide in an area of about 250,000 people that we service. This is capture rate on tests, so we're just starting to see that. But again, it's the workforce issue for us.
Well, I think that makes some sense. We're hearing it from everyone. The workforce is the issue. Our numbers today, we have 17 active inpatients. We have 42 overall. We have 2 in the ICU and 2 on the ventilator. And so that makes 25 recovering. So still quite a few patients with COVID if you think back to where we have been at some points during the pandemic. I'd also point out that our census today is 841. We are running 95 to 105% of census all the time. So we go above the census of staff beds, which means that there are patients in the emergency room who are admitted and don't have a bed yet, or they may be in what we call alternate care units. So we staff all of our beds, but the challenge is that we're full, and what that means is we have a hard time taking patients that we want to take from other outlying communities. As you heard from Dr. Watson earlier today, say, gosh, we don't have enough workforce, and we don't have enough staffed beds. And even if you staff all your beds are already full, and it's middle of October. This is something we usually see in like November, late November, December, January, February, March. That's what the highest census years traditionally for hospitals. But we're already all peaked there, and that's with our staff, and you heard it too, and this is true here as well. We don't have that many staff out right now. So the real challenge is we just don't have enough folks to work, and I think it gets back to Dr. Watson's earlier point. If your ED transfer ratio, and I don't know what else you call that, Doctor, I called you Dr. Motient, good Lord. Dr. Watson, sorry about that, is close to that 2.5, and you pointed out, we get to 2.7, the system starts to collapse. Wow, we are running on a razor's edge, and we don't have a major COVID problem right now, and we don't have an influenza problem. We have a lot of sick folk problem, and we have a staffing issue. And that's with our staff not being sick. So what happens when the numbers get worse this winter, I think, is a concern, and I don't know that there's any easy answer to that. Let's also talk for just a moment about a new topic that's coming out, and there's an article that was in the Washington Post yesterday. It's still posted there if those are interested in reading it, looking at it because there is a concern about the types of and the numbers of COVID variants that are out there. Now, the CDC, remember, has 3 categories: variants of concern, variants of high consequence, and variants being monitored. What we have right now is there are a lot of variants being monitored. In fact, if you look at some of the data, there are about 11 different COVID variants being monitored. None of them yet are classified as a high consequence. But the news media and the CDC are now talking about a swarm of variants, meaning lots of different variants that could fuel a surge. We're already seeing a shift here in the United States. Before we were all BA4, BA5. Now we're seeing some of these other BA whatever, or the XBB or other things that sound like a Star Wars lingo. It begins to show us that we're seeing more of the rise of different variants. And what we don't know right now is how successful therapies or vaccinations are, or especially prior infection, to preventing that from becoming, having us get really sick. So in other words, instead of a single new Greek letter variant, a group of potentially immune-evading Omicron spin-offs, or even others that aren't related to Omicron, are starting to pop up all over the world. We're going to take a little bit more of a deep dive into that. So let me talk with some of our folks here on the call, and I'm going to just start. Kevin, I know you follow this pretty closely. What are your thoughts about this potential swarm? What does it mean? Are you concerned?
I think certainly it's a cause for concern. I think our recommendations are going to be what they were throughout the pandemic. I think we have to take precautions when we are sick. We have to make sure that we're isolating at those times, doing the basic things that we've always done, hand washing and ensuring that we're doing everything we can to prevent transmission first and foremost. You're right, Steve. The great unknown is how effective we're going to be as we see this swarm of variants, and how we're going to address that from a vaccine standpoint. And the fluvid's going to be extremely important. But I think we have to remember the back to basics approach and ensuring that we do everything we can to keep ourselves and others around us from transmission.
Yeah, I think that's right. And Dr. Hays, our CMO at Advent, as I look at this number and I think about how tight beds are, Are you guys talking about that internally and how to think about, gosh, how are we going to respond to this if things get worse again?
Yes, and we're constantly looking at how many new nurses we have coming, how many agency we need to help staff up so that we're able to meet those demands, and trying to have a crystal ball to anticipate what the needs are going to be in the future. Just to touch on what Dr. Dishman said, can just continue to emphasize to our staff to make sure that they're doing things to stay healthy so that they can come to work. Making sure that, if they're going to a public event, consider masking if they're concerned that they may be exposed, testing before family gatherings so that they're not spreading at those intimate family gatherings, but really emphasizing prevention so that we have enough staff come the winter.
Heather, the challenge is probably different with Hays, just because, in Kansas City, maybe we can find a traveling nurse from around, but when you guys get backlogged, it's probably pretty tough to find contract labor.
Absolutely. We can't borrow anyone from across town. So yeah, we have to be kind of creative where patients can be, using units in alternative ways that we don't normally use. Is some things that we have to do. We've seen a little more lengthier stay in the emergency room, which is not something we're used to out here, particularly with mental health patients. That's not been something we've been accustomed to. So that's been kind of unique. And just all the providers trying to come together to figure out how to best service those patients. It becomes difficult and challenging, and just trying to also get the patients out. That's been another really a struggle and hurdle for us. That there are patients that could go to nursing home, skilled care, swing bed, etc., and those doors seem to be difficult to get through as well. So I think if we can continue to really work with that's where we can use the critical access hospitals and the skilled care and the swing bed units to try to get people out the door so that we can take more of the acute ones.
Makes sense. Now, Dr. Camero up in St. Joe with Mosaic and all, you guys do service a lot of rural hospitals. Are you seeing the same stories there in the smaller hospitals that are part of your network, that there just aren't enough staff? And what are you doing to try and prepare for the winter?
So we've actually done we've weathered the staffing storm a little better than a lot of my colleagues that I talk to. We've been fortunate enough. We are blessed with a few things. We do have a pretty good workforce. We also live in an area that has a very low degree of enthusiasm for vaccines. And so that has been an issue for us. But one of the things that we've done that's been really helpful is we have a critical access, we have a dish hospital, we have a soul community, and we really have been moving people back and forth effectively. We started that early in the pandemic. And so we use our critical access hospitals to offload those COVID patients as soon as they don't require the higher level of acuity or care. We'll get them over to Albany or Maryville, and that flow inside of our system has been fantastic. Obviously, from a governmental standpoint, to me, one of the biggest things is that flexibility. I'm afraid we've lost that flexibility without having the pandemic status, because critical access hospitals have length of stay requirements and so forth. But some of these COVID folks, as we all in this discussion know about, they'll stay with us for weeks because they're just not able to get up and get going. And so that does play a role, but otherwise, they can be a significant asset to offload some of those folks as soon as they're past the acuity. And we really had great reception of that.
So Dr. Long, as you think about Olathe Health and what's going on in the southern part of the city, tell us what you're most concerned about the challenges for the coming winter.
I think it's going to be echoing what most everybody has been saying, is we don't have a cushion, and we're seeing longer wait times in the ER, especially with our mental health patients. That is, I think, a crisis that is unfortunately not going to be easily solved. And it is that it comes as a crisis when it is your family member and they need a time-sensitive treatment, and they're not getting the quality of care based on these limitations that could be provided for them. And I think that is something that is going to be very frustrating And we have to continue to be creative in all aspects in trying to deliver that care for the patients. And I think, if anything, COVID has created a creativity. How do we do this? How do we attract more nurses into the nursing field? How do we, do our farm teams? How do we do this? Because we have to have our eye on the prize in 2 years, 3 years, even 5 years, because there's really not a quick fix for this.
Mark Steele at University Health, and you guys, you have a sick population. I got to believe that mental health point really rings true. I know it rings true here with us.
Yeah, no, I mean, I think all the concerns that have been expressed are similar concerns that we have here in terms of trying to get staff. And sometimes we're reaching out for agency staff and the agencies can't get us anyone. We run a number of inpatient behavioral health beds, and staffing also is a problem there. So sometimes we can't even open every single behavioral health bed because of our staffing challenges. Have the same issues for long stay patients and trying to get them into long-term care, and there's nowhere for them to go. So yeah, I mean, it's clearly worrisome, and I'm not sure that there's a quick fix for any of this. And hopefully the winter doesn't bring us the number of COVID cases and flu cases that we're all potentially concerned about. I mean, the other thing I might add, I mean, obviously besides all the subvariants, we already know that in the United Kingdom that the number of cases over the past month have nearly doubled. And what happens in the UK and Europe typically makes its way here. And obviously they're seeing some of those new variants rise, and already are the dominant variant there compared to here.
Yeah, so Dr. Stewart, as you look at the Northland for this year, you guys still obviously have quite a few you had 16 patients today, and what would happen if you had 60 or 70 patients again? I mean, at one point you guys got up to 100 COVID patients like last winter. What's going to happen if you get up like that this year?
Well, that's a great concern. And I think that the census numbers over the last month or two have been really high, and more like we have in the winter. And if it proportionally goes up like it does every winter, then I think that it's going to be tight, and it is a concern. I think that, during the pandemic, when we had those 100 COVID patients, we were giving bonus shifts to nurses and overtime, and it helped us with staffing, but it wore them out. I'm concerned about the nurses' mental health and the nurses' physical health because of that.
Yeah, I think that's right. And Jackie Hyland, one of the things we've heard of this theme of mental health, and you stressed that for us before on our calls. How are you approaching that? What are you trying to do to keep your team healthy?
A variety of different things. There's a lot of, connection from the senior team, a lot of rounding, making sure that questions are answered by the staff, letting them know how, when they're feeling really busy and strapped, that we have, our plan for bringing in agency to support them. Lots of, bringing in pizza and Chipotle and different things. And, you don't want to bring in too much junk food. But, so you have to balance the treats with making sure that even though we're paying them extra for additional shifts and bringing in people to support them, they really need to make sure that they're taking care of themselves and taking care of their family and doing what they need to do. So a lot of open doors from the directors, managers, senior team, making sure the frontline staff is supported.
I think that's right. But I do have one thing I want to point out. When we're trying to lose weight, we call it junk food. When we're trying to relieve stress, we call it comfort food because we want to feel better about it. But really, it's the same food, right? It's still, so let's just call it comfort food so we can feel better about it. Hawkeye, this viral swarm thing and COVID swarm, and you and I have been talking about it a little bit. I'm a little nervous about what could come down this winter. Where are you?
I'm certainly, again, I think we talked about it a little bit. Everything that's old is new again. We've seen these variants come up. We've heard about evading immunity. Really, we have to focus on what is that immunity. That immunity tends to be the antibodies, and we know that our antibodies are so specific. They're so fine-tuned to every little pathogen that we see, every little insult to our body that we see, even on a daily basis. So it's not unheard of, and it's not surprising that any new variant with any type of change or mutation in that spike is going to evade those antibodies. I think what's more important is that throughout the pandemic, what we have seen is that those spike proteins continue to have 80+% conserved areas that our T cells react to. So I think that's important. So I think I'm not as concerned, but I'm also worried about the other parts of the genome, the other parts that allow that virus to evade our immunity or not be tampered down by our immunity so much. And we need to get into doing that science and asking those questions. We are doing it, but it does come slow. We know that you have to work on those viruses with those BSL-3 labs, very high quality labs. So the research does take time, but I'm not as worried because also what we have seen is even the original vaccines continue to have very good protection against the variants that we have seen. So hopefully we will get some of those answers, and I think it then becomes incumbent and imperative upon every individual to make sure that they are as immune or protected as possible, and that is by being up to date with those vaccines.
All right. Jess, let's see what questions we may have from reporters or from the community.
Dr. Stites, good morning. Okay, so I do have a question from Rita. Rita says that there's some kind of upper respiratory virus that's been going around at schools. One class was reporting like 8 to 10 kids possibly having this. She was wondering, could this be one of the new variants that's going around?
Okay, Hawkeye, I got to tell you, I've not heard about that new variant or that story. We are seeing some influenza. We're still seeing a whole bunch of rhinovirus. We're seeing a lot of the enterovirus. We've talked about that. RSV, especially with younger kids.
Yeah.
But I don't know. I mean, it's estimated that 10 to 20% of cases in the U.S. are no longer BA.4/5, so there are one of the new variants. But I've not heard anything about it causing just fatigue.
No, I would agree with you. I think that we are in this respiratory viral season now. There are other respiratory viruses. My initial thought, just as you said, would have been the rhinovirus, which is one of the most common cold viruses out there. A little bit more hardy. We know that there were huge spikes of rhinovirus even during that first wave of the pandemic when everybody was wearing masks. So I suspect it's another common respiratory virus. Probably my guess would be that rhinovirus, but we know there's other ones out there. I wouldn't think it's any one of the new variants at this point.
Yeah.
Dr. Stites, Sandy wants to know, has the system collapsed or did it collapse at all during the pandemic? If so, when? And if not, what does an actual collapse of the system look like?
Well, I'm going to turn to Dr. Richard Watson to help with this question, but let me just, I'm going to give you my view as CMO here, and I'm curious what some other folks think too. Collapse is not a single point in time. It is this process by which things are going from stable, we're taking care, we can get the transfers up from outside hospitals, and we can make sure everybody gets cared for. When you start seeing challenges in time-critical diagnoses because you're too full, you can't get a heart attack, you can't get an infection in soon enough, you can't get a car accident in as fast as you want, or somebody who's bleeding. When people have to wait and they delay, then what we know is that outcomes are worse because it makes our bodies more vulnerable. We're not getting necessary therapy. No question we were there last winter. No question we were there last winter. So if we define collapse as not being able to take care of time-sensitive diagnosis, Dr. Watson, I think we were there last winter. I think we've hit it a couple times this pandemic. Your thoughts?
Yeah, it's interesting. I've used the collapse word several times, and I get different responses. Some are appalled that we would even mention that the system might collapse. But I think we have to realize that when we get to a point where mortality is rising in relationship to systems and processes that we have in place are failing, then that's a point of collapse. And we have to realize that we deal with things because the situation is in front of us and we do the best we can. But at the same time, when even the mitigations are overcome by either disease process or the lack of resources in place, and outcomes then are not only affected, but mortality is in fact affected, then that's where collapse becomes the story. And I think it's an eyes wide open moment where we have to realize we don't want to go back there again. And we need to realize that there is a critical healthcare infrastructure in this nation that has to be incentivized. Margin is the theme here. And I think everybody is saying we don't have margin in the system. So how do we use the resources that we have at a federal level to incentivize margin, not only in things like ventilators and PPE and all these sort of physical things, but what does it mean when we talk about workforce margin and reimbursing for workforce margin at a very basic level as a national security concern, not just because there's some profit behind it or people are trying to get higher reimbursement, whatever. We have a real critical healthcare infrastructure that needs to be supported at a very basic level.
Yeah, I would say here, just I don't know if anybody wants to know the finance story, and just maybe we need to do a new financial deep dive on this program coming up, because there's pretty good evidence out there. If you look at Standard & Poor's, Moody's, Fitch, the people who rate healthcare, we are getting a negative outlook. And getting a negative outlook is bad news, because it makes you can't go out and borrow money. It makes it a lot harder to get the bond market, and plus, rates are pretty high anyway. But as a result, we can't invest like we've been able to in the past in new structures, et cetera. So healthcare is under stress. We don't have enough people who are working. The contract labor prices, the price of labor have gone up dramatically. And I'm not going to tell you the nurses shouldn't have been paid more, because nurses should have been paid more. I have no problem with that at all. But the reimbursement does not keep up with those changes. And one of the worst offenders, frankly, is Medicare, because they continue to cut reimbursement to hospitals. The average hospital margin is around 2%. Compare that to pharmaceuticals, which are much, like 10 or 20 times that. So at our level of reimbursement and our level of margin, even though we are forced to conserve as much as we can, the healthcare is struggling. Added to that, what we see is a coming surge this winter, a lack of folks who are employed, or not enough folks who are, especially in the frontline healthcare workers, to take care of the folks we're afraid we're going to have. I think we see a potential double hit. So I'm going to turn to Dr. Freeman. What is your sense of all that? You guys have a large hospital in Topeka. Give me your thoughts. But don't forget to unmute. Who did I call on just now? Dr. Dishman, I meant. Good Lord. Sorry about that. Freeman, Dishman. Oh, my God, I've done that before.
That's all right. We're even now.
I've got a COVID break. Actually, I don't.
I need to echo what Dr. Watson said. This is a matter of national security, and we must drive forward the understanding at a national level that we have to look at healthcare the same way that we look at finance, the same way that we look at national defense, the same way that we talk about education. This is a critical part of our infrastructure. And this is an infrastructure that has relied for many years on the goodwill of the people who deliver that care. And the fact that the public trust is that they're always going to be there for them. And I think it's high time that we move this discussion to a level of importance that equals the other key components of our infrastructure, which of course are finance, security, and education. So I would challenge our national leaders to bring this to the forefront, to develop an appetite to better support healthcare in this country, and to make the commitment that we are going to continue to have high quality, safe, and well-supported healthcare throughout the nation. And that's a challenge that I think the public needs to carry forward, and the ask that we would have. Support us by making sure that your representatives, your congressmen, your senators, and the very leaders of this nation know the message that we are bringing to you, which is that our teams deserve that support, they need that support, and we need to act quickly to prevent the events that we are talking about here today.
Yeah, I think that's right. And I think to Dr. Watson's point, we clearly did collapse last winter when we couldn't get people in, we couldn't get folks taken care of, the ERs were overwhelmed, and patients with heart attacks were dying in rural hospitals. They couldn't get transferred to get aggressive care. So did we collapse last winter? Yeah, you bet we did. Now, does collapse mean that every building fell down? No. But did we get people taken care of and we save as many lives as we should have? No, we didn't. And so again, it's all, there's no cutoff point here. It's just a sort of slow motion. Things get a lot worse, and then slowly things get a little better. And I just don't think anybody wants to be caught in that bag of worse again. So, Jess.
Quite a few good questions today, Dr. Stites. I'm trying to get to some of these. Barbara wants to know, when will KC add to mental health beds for children and adolescents? She thinks this is really concerning.
Yeah, boy. Okay, I got to be careful how I answer this question. Right. So we have both an adult psychiatric hospital and a pediatric and child psychiatric hospital, and those are great things. But I'll tell you that we are terribly underbedded in Kansas City for behavioral health services. But I'm being really honest. Part of the challenge of behavioral health services is reimbursement is so lacking that if you don't do well financially in other areas, you can't come back and service those areas. And that's what we're talking about before. This is a national challenge to us. So let me turn to Lisa, Dr. Hays at Advent. You guys have a large adult psychiatric commitment as well. And I mean, it's tough to get more behavioral health when you lose so much money at it.
Exactly. And that's a big part of our gridlock in our ED is patients that are involuntary admissions waiting to be transferred to a state hospital or another hospital that can properly care for those patients. We desperately need more involuntary beds in our state to properly care for those patients. It is amazing to me the number of mental health patients we're seeing come to our hospital on a daily basis. And it's not acute psychosis, it's things like alcohol withdrawal. We all are aware that alcohol use increased during the pandemic, and now we're seeing the backside of that effect. And all of those individuals need cared for. It's definitely creating a burden on our health system for sure.
Yeah, I think that's exactly right. And I think this behavioral health question is really hard. And so, Dr. Steele, University Health also has a big commitment to mental health services. I know we get overwhelmed by that. I'm betting you feel the same way.
Yeah, no, absolutely. As I mentioned earlier, we have a big commitment to behavioral health, but still part of the challenge, and we're actually talking with the state about potentially adding new beds. That's obviously a long process and doesn't happen overnight. But in the same vein, we're also worried, and when we talk to our psychiatrists, where are the staff going to come from? So the staffing issue, even if we build more beds, are we going to be able to staff those beds? And so that continues to be a challenge. I do want to mention, in terms of the economics, I think people are aware that last year that over half the hospitals in the U.S. lost money. And I don't see these expenses going down anytime soon. The amount we're paying for agency right now for us is about tenfold increase from pre-COVID, and the revenues are not increasing. So something's going to have to give with that. And also, obviously, to build out more behavioral health beds and to be able to staff those, we're going to need more support to do that.
Yeah, I think this is one of the greatest challenges of our time, is how we're going to handle behavioral health services with a very strained and stressed healthcare infrastructure, and it's hard. It's really hard. Jess.
Dr. Stites, I've got two more questions for you in the panel, and then I'm going to hold our COVID questions for Dr. Hawkinson tomorrow. So this is a question from Anne. Is there a larger role that family members could play in the care of inpatients to help stretch the nursing care?
That's a great question. So I'll let the panel tackle this with me, but I think my first answer is it's hard to say that on a consistent basis because A, not everybody has family members, B, not every family member feels comfortable, and C, there's a lot of inconsistency in it. And healthcare is the best delivery of healthcare is built on consistent services and systems so you eliminate errors and you make sure care gets delivered in a timely and safe fashion. And when you go to a family member and expect them to be part of that, it just creates a potential for error because you just don't know their level of expertise and level of commitment. Let me see if others share in that opinion. I don't know. Dr. Stewart, what do you think?
Yeah, I agree with that. Trying to place the inconsistency of the care is the biggest concern, I think. We don't know what these family members are capable of doing. We don't know what their training is. And even though they love their family members as in the hospital, it's not something you can just step in and do at the drop of a hat.
Yeah, I think that's right. And Dr. Long, I know you're a surgeon, and that would be especially difficult in a surgical ward, I think. We have wounds and post-op care, et cetera.
Well, it's always wonderful if you have that highly engaged family member that is an asset to the patient's care. We can't always rely upon that. And certainly, from a liability standpoint, I think that would be a very difficult, slippery slope as far as documentation of the care that's given to the patient. Certainly, I appreciate it when the families are engaged and can be educated, especially for the care following dismissal from the hospital. But I don't think that I foresee that being a strategy that we would utilize in our hospital.
And Dr. Harris, I'm guessing the same thing at HaysMed?
I mean, correct. I think from the day-to-day cares in the hospital, I think I'm not sure how helpful the families may be. I think the family's role, certainly in the elderly and the folks that are, have more trouble being relaxed in the hospital, I think being around them and make sure to help improve their safety in the room so that they stay, in bed or safely in their chair. I think there's some advocacy for that. I think if, families, I think really the prevention is where they can help the most, and being vaccinated. And if you have elderly grandparents or immunocompromised family, is being very careful around them during the next several months to try to get, to avoid being sick. I think that's where the family can be the most supportive.
Yeah, good point. Jess, anything else, or we're going to wrap up?
Yes, last question from Lesko. If COVID-19 vaccine mandates impacted staff on our area hospitals, has anyone on the panel considered not mandating vaccines to help increase staff and encourage more people to come join the hospitals?
Yeah, we have a COVID-19 mandate for getting your original vaccination, just as we do for influenza, tetanus, diphtheria, and other things. We just didn't lose many people around this COVID vaccine question ultimately. And I'm going to guess that's going to get shared by everyone. I see Dr. Hays, you're shaking your head, yes?
Yes, exactly. And we know the evidence supports the benefits of vaccination, whether it's against measles, mumps, rubella, influenza, COVID. And our team members are supportive of evidence-based medicine, and that's why they work in healthcare. So we did not lose a large amount of individuals to the vaccine mandate.
Yeah, I think that's an evidence-based point's great. Dr. Kammerer, any thoughts around that?
Same exact story, less than 1%, attrition from that. We kept track of that very closely, and again, it really wasn't a factor. So.
Yeah, Hawkeye, sometimes it's just got to die. COVID vaccines don't kill you. They're not dangerous for you. We just got to get over it. The evidence is overwhelmingly clear that they're helpful, and they are not harmful.
Yeah, and the other thing is, too, is remember, those vaccines were new. There was a lot of mortality and morbidity with that. We know that there is a large population of childbearing women as well who are working in the healthcare system, and so they are getting their other vaccines to be protected for them and baby. And we know and have good data to support the fact that these COVID-19 vaccines protect both mother and baby as well. Even was just looking at a study just now, even through the first 6 months of life, you had a reduced chance or reduced rate of fetal or baby hospitalization from COVID-19 in those babies that their mothers were vaccinated prior to birth. So I think it's all important, and we're still kind of pressing that, and we just want everybody to be healthy and be able to work as well.
Yeah, it's just dumb stuff at this point. The people are still fighting about that. That's just internet ridiculousness, I think. Twitter tales, Jazz, Twitter tales. All right. Any other questions so far today? We're ready to wrap up?
I'm going to let you wrap it up.
All right. This has been a great program today. I want to say thanks to all the physicians who participated, Dr. Hays from Advent, Dr. Harris from HaysMed, Dr. Stewart from North Kansas City, Dr. Long, Olathe Health, Dr. Dishman, not Free Love, from Stormont Vale, Dr. Hyland at St. Francis, Dr. Steele with University Health, Dr. Kammerer from Mosaic, and of course, our own inimitable Dr. Hawkeye here at KU. Hawk, final thoughts today?
I just think we'll echo, we've heard so many great thoughts from our guests, and we just need to keep doing what we're doing, trying to keep patients and their families healthy, and we'll be here continuing to do that.
Yeah, we'll keep telling the story, and here's what I want our folks to know. You know, we work the hardest at our very best that we can for you every moment of every day. And I think that's true for every healthcare group you saw, every hospital, every health system on the phone call or on our call today. We work really hard, and I really appreciate Dr. Watson's points about we have a system under stress, and until we address it like we would any other part of the infrastructure, that stress can break us. And the problem is going to be if you're sick and you need us and we can't deliver, that's when you're going to feel our stress. We don't want you to feel that. So do your best to try and take care of yourself. Try and stay as healthy as you can. And remember, science, not fiction. And this from the guy who loves Star Trek and loves science fiction. But science, not fiction. Live long and prosper. Jess.
All right, Dr. Stites, thank you so much. And thanks to all of our doctors for taking part in this very important update today. Coming up tomorrow, we continue with our Power of a Second Opinion series with the story of this man who received a devastating diagnosis, but then went for a second opinion, and he got a surprising result. We'll see you Thursday at 8.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now, everywhere podcasts are available.